So, good evening, everyone, and a very warm welcome to yet another learning session presented by Association of Nurse Executives India's Patient Safety Fellows. We are very proud of this series, which is being, held by Patient Safety Fellows discussing actionable evidence-based practices. So, just give me few minutes before I hand over the podium to our fellows today. So, as you know, that this special series have been started this year, and every month we come up with one topic. And in September, we had Patient Safety Conference, so hence we did not have any sessions last month. So this month we have two. We have one today, that's 18th, and the next one will be on 24th. This is something that we are committed to ANEI as an organization, and with the ANEI Patient Safety Fellows, we had been webinars, continuously since the time we started. And this year, our focus is on evidence-based practice, and we had been doing that from January. And if you have not seen any of those sessions earlier ones, we have all of them on our YouTube channel, Association of Nurse Executives India's YouTube channel. All the webinars are available. And I really feel that these recordings should be used by, hospitals as CNE, and also for students. They can go through this webinar and probably facilitate a discussion soon after that. So we can spread the effort that is being done by all people who care about patient safety, which can be used by others in the academics and services, and multiply the effects of this one activity. So once again, evidence-based practice in nursing involves providing holistic quality care based on the most up-to-date research and knowledge. Now, this is very important. Unless and until we keep ourselves updated, we would not know what are the current thoughts around anything that we are looking at today, as we are nursing our patients. We all might have passed out different years, and we know that every year there is some new information coming. Now, with the technology, on a leap across time, the knowledge that is being made available to all of us is also that frequently happening. But how do you get the knowledge? That is also pretty easy with all the technology on our fingertips. But our endeavor is that we don't have to worry about reading multiple documents and then trying to understand that what does this mean. So today the discussion is around early mobility management. And ladies and gentlemen, there had been lot of discussions around two topics in the past few years. The one is around nutrition, hydration, and the other one is on early mobility management. So even there are a lot of webinars happening outside the country where we are discussing that how we can mobilize patients even if they are on ventilator. So the discussion is also not to sedate patients on ventilator, but rather try explaining them on those who are on ventilator, explaining them to cooperate so that they are able to remain active. So that is the kind of focus that is being given on early mobility and nutrition. And obviously, when our fellows are going to discuss on this topic, that is Miss Jyoti Meri Kancherla. I'm sorry, there's still a spelling mistake there. And Saujanya Kesara, both our, ANEI patient safety fellows. So they will introduce themselves as to where they are working and what are I should not be doing that. And next on 24th, you will see me along with Papori. So Papori is our patient safety fellow, and I happen to be her mentor. And I also mentor the entire patient safety fellowship program. And it is my passion, and I'm very proud of every single, fellow who is being presented here. And I have, huge pride on each one of them. Thank you very much, all of you, for being here today. And now let me call upon Jyoti and Saujanya. So I would like both of you to say a few words about yourself, that, your background a little bit, where you work, what's your designation, and then you can get into the session, and a little bit of hygiene guidelines to everyone. Please keep yourselves muted, and also keep your video also off. And as the session is progressing, in case you have any comments or questions, please put them into the chat box. At the end of the session, we will take them up. And also, we are facilitating e-certificate. We will not be able to send it automatically, but whoever is here towards till the end, they will get a link in the chat box. And if you fill the feedback form today, one of our other fellows, Vijaya Tongam, will ensure that you receive the certificate in the next 1 week's time. So I hope that is exciting. Then you can tell your colleagues, oh, you're getting certificate, please join. So it'll be nice to have more of you here. So thank you once again, and all the best. Jyoti and Saujanya, over to you. Please don't forget to introduce yourself and then your session. All right.
Thank you. Thank you so much, ma'am, for the kind introduction that you have given to kickstart our this today's session. I am Jyoti. I am working as an assistant nursing student at Krishna Institute of Medical Sciences, Hyderabad. A warm welcome to each one of you who are joining the Zoom for this actionable evidence-based practice session on early mobility management. Over to you, Saujanya.
Good evening, ma'am, and good evening, everyone. A warm welcome to today's session. Myself, Saujanya, I'm working as a nursing manager at Rainbow Children Hospital, Hyderabad. And once again, I thank you for allowing us this presentation, ma'am. Over to you, Jyoti.
Thank you. Let's get started with our presentation. Just a moment as I pull up my slide. Just to confirm, I hope my screen is visible to all of you.
Yes.
Yes. Thank you. So as many of us know, that early management in healthcare setting, particularly in critical care, has shown significant improvement or benefits for our patient recovery. And it is a practice that not only it improves the physical outcome of our patients, but also enhances the overall quality of care by reducing complications such as muscle weakness, delirium, and prolonged hospital stay. So here we are, myself Jyoti and my mentor Saujanya are going to present to you the latest research, strategies, and best practices in early mobility management, and how, as we healthcare professionals, can implement these approaches to improve our patient outcome. So moving on to what is mobility. So as we all of us understand from the term mobility, it is all about the physical activities which are necessary to maintain the patient's physical functioning. And it also helps a person to maintain the muscle function, whereby we can prevent most of the patient falls. So now it's time for us to understand why are we talking about, or why early mobility management is very important. And I must say that it is the need of the hour, because most often our daily mobility assessments are being performed are there in hospital policies. But when it comes to practice, it is not very much happening as it is told. And this has its own complications and related to the expenditure or cost, which can be incurred for the patient and to the organization as well, as many complications can occur if we do not mobilize our patients at an early stage. And the complications are like pressure ulcer, pneumonia, inpatient falls, infections, and many more. So if we furthermore see the what else, or why is it more important? Because most of the time our patients, especially who are on ventilator, are being sedated. And there is a lot of evidence which supports this statement that in case if we educate our patients at an early stage or before intubating them, or if we tell them or if we counsel them, they will definitely cooperate with us. And without sedation, we can ventilate our patients, which in turn helps them to move, raise their hand, and we can perform a lot of range of motion exercises and we can get their cooperation. And this has significant benefits or improving our patient's outcome, which is not much seen in our current day practice. And also because of lack of mobility or proper mobility, there is, as I have spoken in my introduction, there could be a lot of muscle weakness, prolonged ICU stays, which in turns increases the mobility or mortality rate. And it is seen, or the evidence says that patients who are not mobilized are likely to die, and the percentage is 35%. So this is the intents of this topic, or the necessity for all of us as healthcare professionals to note that early mobility is a very, very important component when it comes to our patient safety and clinical outcomes. Here are some of the clinical evidences, which again says why it is important for us to understand this early mobility management. So there is, in 2011, a prospective longitudinal study was conducted for survivors of ARDS. And it is seen that these patients were followed for about 5 years. It's seen that a significant exercise limitation was noticed among these patients, and also reduced health-related quality of life was seen among them post-discharge about 5 years. And also there was, though the recovery rate among our, these patients were there, but still, I'm sorry about that. I'm sorry. Yeah. There was increase in the cost. There was increase in the cost and related to the usage of healthcare services among these patients. And also there was a study which was conducted among patients, a prospective study among patients who were admitted to ICU. And these patients' muscle mass was checked on day one of admission through ultrasound. And it was seen that, as these patients were not much mobilized, there was significant reduction in the rectus for, femoris cross-sectional area at day 10 among all these patients. And this was significant among, those patients who had multi-organ failure. So moving on to after knowing why it is important, so let's try to understand what could be benefits related to early mobility management. So here I really sincerely want all my participants to think about, a scenario wherein a patient, a young adult who met with some kind of a road traffic accident. Okay. So imagine if he is, and he has undergone some kind of a replacement or hip replacement surgery. Imagine he is not being mobilized and he is over there, not being or confined to bed. So definitely I can say that there could be there could be, loss of their muscle mass, and the recovery time will take, or prolong. And they will find very, very difficult to stand and to walk. So this will in turn, increases the patient, cost factor, and also it can hamper the recovery of our patients. So in this, like this, I would want my participants to think about it and then put your thoughts regarding this in the chat box. However, let's proceed in understanding what could be the benefits of early mobility management for our patient. So if we see, once we mobilize our patients at an early stage, it helps to reduce the degree of muscle loss, which will minimize the poor physical condition of our patients. And definitely it will improve the functional status of our patients. And we can ensure that patients walk at the time of discharge to their homes. And recently, as I have briefed you about one of the study which was conducted, the health related quality of life can be improved if we mobilize our patients early. And also it can reduce the incidence and duration of delirium among our patients. Now let's look at what could be the benefits for the organization. So definitely, once we mobilize our patients, they will get out of our ICUs at an early stage, at an early time, and also which in turn helps to reduce the length of stay, and the infection rates can be kept to very, very minimum. So as our patients get shifted to floors and then from there they get discharged, there will be increased patient flow. And also by mobilizing our patients, our duration for mechanical ventilation can be drastically reduced. Our ventilator days can be reduced. And also the readmission to our ICUs and then readmissions due to falls, pressure injuries can also be reduced to a great extent. And this will in turn makes sure that our patients are satisfied with the level of care that we have rendered to them. So having said about this benefits of early mobility, I would we will try to understand what could be the barriers related to early mobility management. So I would like to ask my mentor, Saujanya, could you please share out of your experience what might be the barriers, to early mobility?
Yes, well, Jyoti, so as you briefly mentioned about the benefits to the patients and the organization, as well as there are barriers to early mobility. And there, though we have a research evidences clearly states that there is a benefit for the early mobility when we do it. But some of the research studies says that 54% of the inpatient days are only being utilized for the early mobility, whereas in 95% of the mechanically ventilated patients are still not being mobilized. So I feel that this could be one of the reason in the healthcare professionals that they have lack of confidence or apprehensive about handling of critically ill patients in the ICUs, because they feel that if we do early mobilization to the patient, so there may be a harm to the patient rather than doing a benefit to the patient. That could be one of the reason what they feel about it. And also the education and the lack of training is also one of the contributing factor what I feel. If they don't have idea about the importance of early mobility and why do we do the early mobility for the patients, definitely they will not put effort for mobilizing the patients. Having said that, as ICU patients are fragile and they need to be handled very carefully. And also, we have many other factors are contributing for barriers to the early mobility. One among is the patient factor itself is one of the barrier, where if the patient is in a delirium stage or unable to understand what a healthcare professionals wants to make them to understand, or if the patient is having a weakness or unable to do it, or many other hemodynamical instability or lack of confidence by themselves due to many other factors, the patient himself or herself says that, so I just wanted to take rest for some time. No, I'm not ready for mobilization. So that could be one of the reason what the patient factors may contribute for barriers to the early mobility. And of course, there are the environmental factors. Can you please move to the next slide, Jyoti, for the environmental factors?
Sure.
So what I feel like is one of the most important factor in the environment is about staffing. Staffing, as we all know that how well are we, all the ICUs are being staffed adequately to handle such type of needy patients in the ICUs. And also the lack of equipments or the limited resources of handling such patients for the early mobility. And if the patient is on multiple invasive monitorings or connected to the multiple monitors, that also one of the reason where they may not able to, do early mobility for the patient. And when it comes to the culture of, organization or with the unit of environment, it's a wholesome, it is a lack of leadership or the accountability. And if there is no the patient champion for identification, or there is a lack of protocols about early mobilization. So these may be a factors which also contribute for the barriers, what I feel, Jyoti.
Well said, Saujanya. So I completely agree with you regarding the various factors. However, as you can see on the screen, it is majorly divided into patient factor, environmental factor, the unit culture, and the environment. So it is very important for us, each of us, to understand the barriers. What could be there at each of our institutions so that we can overcome these barriers and then have this early mobility plan, which in turn helps in our patient recovery. So moving on to the next slide. So it is about the interdisciplinary approach to early mobility. So I would like to, I want all of you to reflect and think about our routine rounds, which we perform on a day-to-day basis. I'm sure all of us have a standard checklist wherein we look at our patients when we get into any patient room. Try to understand and check if or are my nurses adherent to the bundle line care, and are we following the protocols correctly or not. But I would like to pose this question to each one of you, and to think about, can we include this question, about can we mobilize this patient? Because it is very, very important for us to ask this question to our patients, or looking at our patient's condition, to our clinicians, and make sure that check for the readiness of our patient's ability to mobilize at an early stage. Because only when we think about this, we can think about the next step of mobilizing our patients. So when we think about, assessing the readiness of our patients to mobility, so definitely we will think, do my patient have the ability to, get out of the bed, sit and stand, and then try to take few steps. In order to do that, definitely he or she need to have proper nutrition. So definitely, I would say it is essential for each of us to ask this question while we make our rounds at our patient side, to assess and to check if he is or she is ready to mobilize.
I request the audience to unmute, please.
So moving on to the physical therapists who are there, so they can check about the safe mobility progression, and then we can ensure having a tailored exercise program for each individual. And the physicians can help in setting mobility goals and ensuring patient stability. So it is very important for us to have daily mobility team meetings to review our patients' progress as per the mobility goals and adjust the plans tailored to our patient needs. So here we are with the few of the core components of early mobility program. So the first and the foremost thing here would be patient assessment and screening. As I have discussed in the earlier slides, it is very important for each of us or us to understand and to assess our patients to know whether we can mobilize the patient and easy having adequate strength or nutrition or stamina to get up and to walk. Okay, that's the first and the foremost component in our early mobility management. And then it is important or essential to devise an individualized mobility plan. And it is definitely not possible just for the nurse or the clinician to make this plan. We need interdisciplinary team to collaborate with us to make this plan successful. And then once we analyze all of these, it is necessary to initiate this mobility for our patients and then ensure that our patients are safe while we mobilize them. And another important component in all of this is education and training of the core team members, whoever is going to be part of this mobility team. So here we are with individualized early mobilization plans at various settings, like our primary care settings, acute care settings, routine care, and at the time of discharge and transfer. So I would like to ask Ms. Saujanya to take us through the primary care setting and the various other settings where we can initiate our individualized early mobility plan.
Thank you so much, Jyoti, for the detailed explanation about why and what is the importance of early mobilizations. Let me go through about the importance of early mobilization. And the first thing is that we all need to assess whether the patient is ready for the early mobilization. So it is very important to understand the mobility milestone for the patient progress. Next slide, please. And also, we need to assess whether the patient is ready for the mobility, irrespective of the facility wherever he is admitted. Either it is maybe in the primary care settings or maybe the acute care settings, or if the patient is ready for the transfer or to the discharge. We all need to understand, is he ready for the mobility? Is he ready for the discharge? Is the family is about take care of the patient, the patient is immobile at home. So these are the few key parameters what we need to understand. If the patient is in a primary care setting, so what all we have to remember is that we need to assess and document about the patient mobility and the function, and also need to understand and explain to the patient family about why it is very important to mobilize as early as possible in order to increase the patient mobility. And we need to inform or educate the patient on the family about that some of the mobility can be compromised due to the medications which may impact the patient balance, and it may lead to some kind of a falls to the patient. So it may be very important to explain in detail about compromisation of the mobility. And moving on to the acute care settings, so once the patient is being admitting into the hospitals, as we all need to understand and perform the risk assessment for all the patient, irrespective of the criticality of the patients, and need to conduct about what is exactly the ambulatory status of the patient at the time of admission. We need to collect the history from the patient and as well as from the family members. We need to involve the family as a core important aspects in the acute care settings. And we also need to understand what are the current medications are the patient is on, and what may be the impact of these current medication in terms of his mobility concerns. And also we need to recognize for the early mobility scores at the time of admission by using the mobility score tools, which we are going to discuss in the subsequent slides. And also we also need to ensure to take inputs from the extended care family. It's nothing but our family members are the right person to give the exact input about our patients. So what is the status of his level of independence at home, or what is the level of he can able to perform his activities. So we need to take completely inputs from all the family members, which will be helpful at the care facilities. And moving on to the routine care. So what are the routine care we can able to, keeping in our routine practices? So the first and foremost important is we need to understand the patient pain level. So the pain is the most concern for mobilization. So if the patient is under the pain, definitely the patients and the families always says, okay, so it is not the time to mobilize because the patient is having a lot of pain. So as myself keeping into this as a patient role, so I understand the pain level, how important it is to consider before mobilization. And we need to evaluate the muscle waste. If the patients are not being mobilized for a while, so we can understand the muscle get wasted and it will be very difficult for the regaining of the muscle strength. And also, we need to ensure the current and everyday update about the nutritional assessment of the patient. As researchers clearly, or some of the research studies clearly state that there is a correlation of a adequate nutritional uptake for the patient for the early recovery and the physical mobility of the critically ill patient, which is clearly stated that it has to be improved. And nutrition plays a major role for the improvement of the health status of the patient. And there are the tools which will be helpful to understand what is the day-to-day activities of the patient level of functionality. Also, at the BMAT is one of the bedside mobility assessment tool, which will help us to understand what is the capacity for the mobility of the patient, what level the patient can be able to perform his activities on day-to-day practice. Moving on that, so we need to select the appropriate safe and handling equipments to be selected according to the patient needs. That is the most important aspect what we have to remember during our routine care. And also we need to verify the risk and the benefits for the short term and the long term of certain interventions, because it is very important to understand whether this really the patient is required on sedation, or is the patient can be off sedation, is the restraints are important, or how far the restraints are being important. So we need to understand the risk and benefits of these things and need to verify, and accordingly the care has to be provided for the patient. Moving on, so it is very important to, as a team member in the healthcare, so we all need to provide the mobility information which is readily available in the documentary evidences to all the care personnel, so that it is very important for them to understand is the patient is ready for the mobilization. So that scores will be helpful and which should be visibly available to all the care people in the hospital. And as I mentioned about, this is a Berthel index score. So how many of you are using this score in your care facility? So if anybody are using it, I request you can drop a message in the chat box. If it is not been using, I think it is a right time to understand the importance of why are we using this. It is basically used to assess the patient level of activities of daily living, and it consists of various parameters, like 10 parameters about the way the patient is feeding or bathing, grooming, so various parameters, which scores from the 0 to 10, and some of the parameters maximum score of 15. So 0 being as into a completely the patient is on dependent, and the highest score is indicates about the patient is completely can be independently can perform these activities. Of course, this tool can be used as a self measurement tool, but of course it requires a clinical judgment, and assistant is required by the clinical expertise. Moving further, we have this is the bedside mobility assessment tool, which it is one of the assessment can be used for the capacity for the mobility. So there we have the levels of assessment. There's a level 1 to level 4. So where if the any person, if the patient is moving from level 1 to level 4 is the right time to understand he can be able to perform his activities of living. So if the level 1 where the patient can be sit and shake, in the level 2 the patient can be doing some kind of a stretching exercises, and the level 3 the patient can be stand for some time, can make a few steps in the same room. So level 4 indicates that can be walked for some time and with the help of assistive devices. So the each level as a healthcare workers, we all need to understand this importance of understanding from level 1 to level 4 and day-to-day activities. And this tool should be done at least in a twice a day to understand what is exactly the mobility of the patient. Uh, Next slide, Jyoti. So if any of these responses, if the patient says that, okay, if it cannot be able to perform from the level 1 to level 2 or level 2, level 3, so we need to ensure that we should not be forcing the patient. We should maintaining the same level. If the patient is to the only stick to the level 1, so we need to encourage for the level 1. If the patient can able to handle up to level 2 standard, so we need to maintain up to level 2. And these are some of the examples of the way the post-abdominal surgery, where how the patient can be moved from level 1 to level 4, which can be explained for the subsequent slide in detail. And this is a BMAT score, which is actually takes about only 2 minutes of time to complete for our assessment. And whenever there is a changes, significant changes in the patient health condition, so it empowers our nurses to remember the mnemonic of ACT. ACT denotes it is a we need to A stands for assessment of mobility level in a safer mode, and the C stands for the coordinate strategies for strengthening, and the T is for the target for the right piece of equipment. So by looking at this act, which will be definitely will be helpful to understand the BMAT and day-to-day practice as a nursing, we can able to use this. Moving further, so the examples of the routine care, so how does the patient can be moved from one level to another level. So in the level 1, where we need to ask the patient, or else we need to observe the patient, is the patient is able to feel there, or is able to patient can able to lift the limbs, or can able to roll the, or the turn to one side. This is about the level 1 where we understand the patient mobility. Whereas in the level 2, what you can able to understand that whether the patient can able to sit independently at the edge of the bed, can he able to move for at least he can able to hold his legs for at least a 5 seconds, or can he able to sit up straight without holding any kind of bedside rail. So where we can understand what is the level of the patient can able to handle it. And whereas in the level 3, where here we need to understand or have the patient can the patient can stand independently, or at least can he able to walk for at least 5 minutes in the same place, or can he able to balance one step forward or the one step backward. So these are the levels where we need to understand the post-operative patients to check whether the what level of the patient are we handling it now. When move on to the next level, the level 4 and the level 5. So in the level 4, where the patient able to maintain the balance, at least can he able to walk for a few steps out of the bed with the help of any assistive devices. If the patient is able to move out of the bed by using assistive devices, so you can able to understand is at the level 4 the care or level 4 of the patient. If the level 5 is all about Can the patient is able to walk at least in the room on the hall, at least can make the few steps out of the bed and around the room itself without having anybody as help or with the help of only assistive devices. So it means the patient is regained his strength for the mobility. So it's basically these all the levels we need to understand in the day-to-day practices. So accordingly, the mobility adjustment plan has to plan. If any changes or if any mobility changes a status to begin or declines from one level to other level, it is very important to engage the care team and need to provide information that what is the status of the present current status level of patient. And of course, as we all understand, when we have the clarity about the levels of the patient, this definitely will help us in activity based patient assignment. So this is also one of the important tool where we can able to understand in our nurse patient ratio allocation as well. Moving further, so I think these are the commonly used equipments for the mobilization of the patient. So how many of us in your care settings are be using this? Jyoti, are you using any kind of these equipments at your care facility?
We actually exactly not using at this point of time, but then yes, there are some discussions going on to,
Yeah.
get some equipment like this so that we mobilize our patients.
So if anybody is using these kind of equipments at your care facilities, kindly drop a message in the chat box. So these are some of the equipment which can be used for the early mobilization, like slide sheets or maybe the gate belts or a transfer of belts. So slide bands or hose, which are be very commonly used for the early mobilization. And moreover, the patients also feel comfortable, and even the healthcare professional also feel very comfortable in handling of the patients. That's it from my end, Jyoti. So I'll hand over Jyoti. So further continue for the presentation. Thank you.
So here, having learnt about the various approaches towards or how to initiate early mobility program, various settings, it is essentially important for us to have this plan even while the patient is getting discharged or transferred to any other kind of facility. Say, for example, just imagine a patient who has undergone a hip replacement or surgery. So it's very important as we healthcare professionals to understand how this patient is going to be mobilized once he is back home. So as we all of us know that discharge planning happens from the time of admission. This is what we listen and then we talk about. But are we including this particular early mobility plan from the time of admission, and are we planning this for the discharge of our patients? It is an important point for us to think about and then put it into practice. Because we were just having discussion about this particular point. And I would like to ask Saujanya to share her experience, if she don't mind, as recently she also has undergone some kind of surgery. Did any of the healthcare team members discuss with you regarding the discharge plan, and how was the setting of the house, and is there any or anticipate any kind of difficulty in mobilizing and all that? So were you being asked, and were you being counseled, or were you being directed about these things, Saujanya, in any way?
Yeah.
Out
Well,
of
Jyoti, so putting into myself into the discharge or the transfer care facility to home. So as I can really say is that some of the realistic goals, what as a patient I feel, what is as a healthcare professional gives information to the patients completely varies. So now I'm talking like a patient. So if I'm into as a patient role, so now definitely my completely unclear about what I supposed to do. So only the instruction that you should be immobilized for 2 weeks on a bed in a supine position. So for me, listening to the two weeks into a supine position itself made me a lot of anxiety. So and then a kind of thing that wherein am I able to walk? Right. So that is a thing where as a patient feels that, and nobody's asked that, okay, so how are we arranging any equipments required for the home? Because So as I underwent for the hip replacement surgery, wherein I stays in the fifth floor of my apartment. So how do I go from from the basement to the ground, from the basement to the fifth floor? So what are the equipments I may be required? So what is my toilet necessaries to be done? So this is all like very important, because I should not be moving my, the leg, or I should not be flexing. I should not be moving a 90 degrees. So how should I be? So the home environment is most important. What I feel, if any patient is discharging post-operatively, these are the main important points has to be discussed with the patient and the family, so that the necessary things can be arranged, and the realistic expectations should be made with the family, so that both will be prepared together to understand. And that is what I feel it, because I experienced it. So later on we'll be calling to somebody, is finding it okay, and many things have been arranged after getting discharged. So this is what I felt it. So definitely at the time of discharge, yes, it is most important to have a discussion before the patient is being moving out of the hospital to the home. So the home setup has to be made for the convenient to the patient, for mobilizing in a smoother way. What I feel, Jyoti.
Yeah, thank you so much for sharing your experience, Saujanya. So, as Saujanya has rightly said, out of her experience, any mobility equipment that we give it to our patients, it can't be just on the day of discharge. Rather, it should be from the time we introduce that to our patients. So it is very important to discuss about the various changes that may be required once the patient goes home. So where is the, which room is he going to stay? How far is it from, from his bed to the washroom? Can he move? And in case if we want him to use the walker, how to adjust the height of the, walker. So these are some of the important things which, we have to educate our patients when they get discharged, and some kind of changes that might require in the home environment to accommodate his mobility needs. So as we were discussing, necessary to ensure and educate our patients and look out for the equipments that he or she might need. And not just that, leaving the patients, yes, they got discharged or transferred out from our facility, but one should have a follow-up plan with our rehab services, how he is performing, or at what level is he returning back to his normal activities. Uh, and also it is important for us to debrief any kind of adverse event that can happen, like falls, delirium, pressure ulcers, any kind of functional losses because of immobility. So here, the next discussion is about patient safety considerations while we have this early mobility plan. So before I could proceed, I would like to ask Tankam ma'am if she has any of the, if ma'am can share her experiences related to early mobility. Ma'am?
Yes, yes, I'm right here. I'm right here. Just managing the, back end.
Yeah.
And your session is going very well, and a lot of practical points are there. If you look at the way that we have been trained in nursing, mobility is definitely a part and parcel of our nursing care plan. But unfortunately, just like nutrition and hydration and patient mobility, we are kind of waiting for someone to come and tell us, move the patient, keep a watch on the meals, keep a watch on their intake output. I think it is high time that the nurses should take the responsibility with the kind of education that we have received. Then in some point, people complain also. Now the nurse's role is being taken by XYZ. Now, nurse's role nobody can take. For example, if you have got a patient with knee replacement and they are on a rehabilitative mode, they have to start exercising. So me as the nurse, I know that the patient will not move if his pain is not taken care. So she has to liaise with the, the physiotherapy and tell that, when you come to move my patient, please check with me whether patient has received his pain medication or not. Right. So are we taking that responsibility, or when the physiotherapists come and when they're going back, they say, that, um, you know, patient is refusing to move, then are we really concerned that refusing to move is not good for them? So we have to go back and counsel them. Uh, I I have my personal experience where, my mother had a patellar injury, and then she was in hospital for 3 or 4 days. And then she had to be brought home, and then we have to give her physiotherapy. She's 87. And today she has still got pain because she just could not do all the things that she was supposed to do. She refused to do. And the doctor was of the opinion that anyway she's 85, so don't pressurize her too much. But what happens to younger patients? Do
Correct.
we take their excuse and we allow them to, kind of let it go? So sometimes patients will take their own responsibility, but then when they are under our care, we need to think for them. And while you were looking at the level 1, 2, 3, 4, the mobility level, I just wanted to add was that it's an assessment. You start doing from level 1. If they cross the level 1, move to the level 2 action, then go to the level 3 action. So you don't go and tell a conscious patient to start with level 5. That is a takeaway that everybody should remember, because we have learned this. Ask the patient to slowly sit up, and now ask the patient, is
Exactly.
he okay? You know, now slowly ask him to stand up and see that if he's feeling, I was not aware of these tools. I wish if I was aware of these tools, I would have definitely incorporated that into our nursing care when I was in Fortis for sure. So I don't think that anybody opined here that they are using any of these tools. But I think it's a powerful tool to use and incorporate into the nursing care plan.
Mhm.
The nursing care plan should not be for accreditation purposes. The care plan is for execution purpose. I think that is what I would like to see here. And I think Dr. Jyoti Chaudhary here wants to share something. Just hold on for a minute. When they finish with the discussion, we'll come back to you, Dr. Jyoti.
Yes, sure.
Yeah. Carry on, Jyoti.
Thank you, ma'am, for giving your valuable inputs. We will proceed with our patient safety considerations. So, as we were talking, that early mobility is important. However, considering the patient safety is utmost important, because these patients are at high risk for falls, because they are trying to, get out of their bed. Their stamina would be low, their nutrition might be less, and their muscle strength might be very weak. So therefore, we have to keep this in mind and make sure that we use appropriate assistive devices to prevent falls. And then we have, our staff are trained properly to handle our patients correctly. And also we have to monitor and identify patients who are at high risk for falls. And it is important for each one of us to have this risk management. That is, as I could see even in the chat box, that fear is one of the major barriers for, mobilizing oneself. So as you have rightly said, it is one of the major risk which is associated. So addressing their concerns is very, very important, because the minute we start talking, that is when they will try to vent out their fear and anxieties, and we can counsel them and build up confidence so that they can get out of their bed and they can move around. And it is also equally important to ensure that the environment is safe, the hallway is clutter free, and then there is something for them to hold on and then to walk around. So gradual progression in physical activity to prevent overexertion. So we can't force them to take more steps, or yes, you have to walk from there to here, but then we have to allow them to do it at their own pace, at their level of confidence. However, keeping in mind, as we have recently just discussed about the various levels, proceed from one level to the another. Let's not try to jump just because we want to make our patients to move, because that could be one of the risk factor, and it's a patient safety concern. So here we are with our patients and family education. So this is one of the most important slides for our today's discussion, I feel. Because unless and until the patient and the family understands the importance of day mobilizing, this is not going to happen. Because one has to be convinced and accept that it is necessary or important for me to get up and walk. If they are not convinced, come what may, whatever we put our efforts, it is not going to be successful. So therefore, we have to put every effort to make them understand the importance of mobility and the risks that are associated if they don't mobilize. And while we educate them, we also have to tell, because the minute we start educating them, motivating them, so they will become super excited, and then they may overdo things. So we also have to tell them that to watch for any signs of lack of stability, like as they get up, they may have little balance, loss of balance, they may get fatigued. And while they are walking, maybe there could be some technical glitches or issues with regard to their equipments itself. So apart from that, we should also demonstrate the mobility assessment. So as Saujanya has very well explained about the BMAT, that is about the mobility assessment. So we have to very clearly educate the patient and also the family about the mobility level of the patient. And 100% we have to look out for any kinds of pressure ulcers, and we have to very well explain the patient that they are at high risk for falls, and then they have to be extremely careful, and we have to involve the family in our mobility plan. And also it is even more essential to describe or explain about the usage of equipment that might be used as part of patient's mobility. So the most common mobility equipment that one might use is a simple walker. So a simple walker, it has various levels of adjustments based on the height of the patient. So if one is not educated, how to adjust the height and lock it, definitely there could be some kind of injury, or there could be some kind of issue with regarding that usage of equipment, and which in turn can cause difficulty for our patients. So we can never miss out this particular point of medications, because patients can have medications which can impair, or which can become a hurdle when it comes to mobility. Like some patients, some medications might sedate our patients. They may feel dizzy, and all these medications will interfere with our mobility program. So it is necessary that we educate all of these points to our patient, and the family should be active member when we are actually educating this to them. So here we are with our recommended early mobility improvement team. So I would like to just pause myself and would like to ask my participants, um, as I have, previously also asked, do you have a mobility team? So this is the best practice. It is the proposed mobility team from various researchers, and from the actionable evidence that we have this list of members part of our improvement team. So do any of the hospitals have this early mobility improvement team? If so, I request you to put it in the chat box. Once this is done, we would like to get back to you and would like to listen from you how this team is formed, and how the team is performing the tasks in your facility. However, the team members goes like this. There should be a physical therapist, occupational therapist, nurses, physicians, anesthesia providers, admitting and registration staff, central supply, quality improvement specialists, case managers, then social workers and psychologists. So having learned about the various benefits and the various levels of mobilization, various assessment tools and all of that, how much ever we want to mobilize our patients at an early stage, make sure that they recover very fast, there are some of the barriers which can come our way while we mobilize our patients. I would like you to think about the various barriers that can have in mobilizing our patients. So, however, I have charted out few from the actionable evidences. That is, in order to mobilize our patients, we need to have adequate hands. So the major challenge could be lack of staff and also adequate training when it comes to usage of any kind of equipment, or how to make the patient get up out, get out of the bed. So sit at the edge of the bed, then make them walk. So lack of training could be one of the challenge, and resistance due to fear of patient injury. So healthcare professionals themselves can have this fear that, oh, what if I'm not able to balance the patient, and then, because of me, if the patient, gets some kind of injury. So that could be one of the fear in them. And also, that same fear can be there on the other side. That is, our patients also can have this fear that, they might fall or may sustain some kind of an injury. That could be one of the major challenge. And high workloads leading to prioritization issues. So if you see mobility, definitely it takes one time. Because it's not going to be an easy task, and one has to really spend time in making this happen. So high workload leading to prioritization issue, of the issues can become one of the challenges. However, we can think about educating our staff on benefits and safety of early mobility. So if the nurses or the healthcare professionals are convinced that early mobility is definitely going to be one of a powerful tool in our patient recovery, then I'm sure definitely one will definitely put their whole soul in making this happen. So educating our staff is of utmost priority. Then mobility protocols, and ensure there are adequate staffing levels. So here, having a mobility team is very, very important, and this can actually eliminate lack of staffing and all related issues related to manpower. So they can take up the mobility protocols for all those patients who would require mobility, early mobility. And we can think about having use of mobility champions to advocate for this program. So now I think it's time for each one of us to have this mobility champions in our facility, so that we can take this program, initiate and take this program further. And probably we can ensure speedy recovery, and we can have our own metrics to measure how it is impacting on our patients' recovery. So as I was talking about the metrics, so there are some key performance metrics which can impact, or which has the outcome. So they are the process related metrics, that is mobility assessment and fall risk assessment upon admission. So here, this will help us to understand, once we start measuring this particular parameter, that is the mobility assessment by using BMAT and fall risk assessment upon admission. We will know exactly, how the progression is happening. And also next one is team communication of mobility scores. So this means that having a visual indicator on the door of the patient, about their mobility status. That is, do they belong to level 1, level 2, level 3, or level 4? So having that mobility indicator, pasted on the door of our patients, or which is put at the head end of our patients. So just like risk for fall, patient first, or safety first, that kind of, caution boards. So having that, it will help the us to communicate to the mobility team about the mobility of our patient. And this will in turn, save the time, and then we can expedite this process. So the next metric would be the bedside mobility assessment rates, that is about the BMAT. And following that is the sedation vacation. That is especially for those patients who are on ventilator and whom we are sedating. So, measuring the appropriateness of sedation vacation. So this we can include part of our various other metrics which we maintain in our departments. So there are some of the outcome metrics, which will directly impact how good, our mobility program is. That is the fall rates. So reduction in fall incidents post mobilization. So I'm sure this is self-explanatory, because if a patient is not sustaining any kind of fall post mobilization, it is a very good indicator that we could, patient nutrition was adequate, and then our assessment levels were correct, and then, our patient is able to walk confidently and independently. So this is a direct indicator. And next metric is about pressure ulcers, that is decrease in pressure ulcers related to early mobility. So I'm sure all of you will definitely agree with me that if a patient is confined to bed, the risk for pressure injuries are high. So once our patients are, out of the bed, then the risks related to having hospital acquired any kind of pressure ulcers or pressure injuries will be relatively low. So this mobility programs will help to reduce the or shorten the hospital stay, as we were talking all through since an hour, that it will help in the patient's recovery. So the length of stay can be shortened by utilizing this early mobility program. So that could be one of our outcome metrics. And the ultimate, metric for any initiation of any program would be our patient satisfaction. So which can be measured through this. So improved patient reported outcomes and satisfaction with care. So this has a direct impact on how good we are having, how good is our early mobility program. So probably we can think about incorporating these metrics into our, nursing metrics, which we, various other metrics which are being captured on day-to-day basis. So this will help us to measure how good our mobility program is. So I would like to summarize our points that we have discussed so far. That is, mobilizing a critically ill patient is definitely complicated, and it is very, very challenging for the healthcare professionals. But having an understanding of why it is important will definitely, will motivate us and will help us to take up this challenging task of early mobilizing our patients. So this will also, throw light or insight to all of us and understand that having appropriate equipment, having processes related to early mobility program, which is tailored to individual patient, is also utmost priority in our patient's outcome or recovery. Having this culture to change and adopt appropriate strategies are very important. And I think all of us are in the right, place to understand the need of the hour, and then, have this cultural change in our institutions and incorporate this early mobility program in our facility. So having this actionable evidence, it is, I think, we can look at our existing policies and procedures and see if we can incorporate any of these into our, day-to-day practices. So maybe, we have we might already have some kind of, mobility team, but we can think about strengthening our mobility team if we have. Otherwise, if we do not have, we can think about having or developing this early mobility improvement team, having focused activity towards mobilizing the patients early. So now I would like to invite Thankam ma'am to take over this.
Thank you, Jyoti and Saujanya. That is a novel topic, though it is not a new one for nurses, but unfortunately, the focus has been lost. You can stop sharing, Jyoti. And see, I can only tell that, unless we start initiating the webinars that I have attended elsewhere outside India, they have been championed by ICU nurses. ICU nurses who initiated the mobility program for their, patients on ventilator. That's the webinar. It was by Arjo plus that person they were talking about that how did they manage, and they showed a lot of photos where patients on ventilator were actually sitting out and some of them even walking with the ventilator because they are conscious, So they had excellent stories to share, but it definitely needs first to break the mental barrier that we have got. That's most important because I think Karishma mentioned here, the fear of, dislodging the lines and tubes could be one reason that, they don't want to do that. So very quickly, because we are already 8:10, so I can just take 5 more minutes after thanking both of you. That was an excellent session. We have started it, and I am hoping that if anyone sitting here wants to do a improvement program, I'm sure that Jyoti and Saujanya can share whatever evidence that they have got with you, that in case you want to do a project, we
Sure.
will be more than happy to, work with you. And it has to start with this BMAT assessment starting at the time of admission. And of course, many of the JCA accredited hospitals have this communication board at the patient's bedside, right? Why not start writing there? What is the BMAT of the patient on that particular day? So in that communication board, you are expected to write what is the patient's minimum pain tolerance level, that particular patient is okay with the 4 or 3 or something. So those kind of very personalized things are important to keep in mind. So very quickly, Dr. Jyoti and Dr. Shubhangi had put a message here that they would like to share. So I would request Dr. Jyoti Chaudhary to very quickly, in brief, please share whatever you have got, followed by Dr. Shubhangi if you are still there. Yeah.
Yes, madam.
Yes, ma'am.
Thank you very much. Actually, initially I thought I have lots of things to share, but this girl, this Saujanya, both the speaker has covered so much. I don't have much to tell. I
Oh,
just want to tell. In same line for early recovery and early mobilization, I had developed one extended nursing care model, which includes early mobilization, but it was for post discharge patient. So
okay.
which starts from the discharge, and in that whatever they have said about the mobilization, fear, and all those things. So we have developed a plan like when to talk to the patient, how oftenly, and also the post-discharge plan is being developed, which starts from day one of the discharge, day three, day 10, then after 1 month and 12 weeks. So we consider it was for CABG patients. So 3 months recovery period we have done, and we have found that early our program within 6 weeks patients were recovered and they were able to go to their job or carry out household work. So that was the beauty of the early recovery in the post discharge patient. That's I just want to say. And interventions what we carried, like as they said, modification of the environment of the patient's house, encourage reassurance, coaching them, demonstrations during the discharge, and on the day three, one outreach visit we had to the patient's house, and that was helpful to reassure them to just see small arrangement in the house, to encourage the even the family members. They are very apprehensive, so that also we have taken care during that time, and that is how we could able to cause the early recovery and good mobilization, I can say. And that is how quality of life has also improved, satisfaction has also improved. Thank you.
Fantastic. Thank you very much for
Thank you.
sharing that. And maybe now you can start the mobilization even while they are in the hospital. So
Yes.
maybe then they can go back to work even faster.
Yeah,
Uh,
that was a part of their protocol. I just
okay.
carried out the ahead.
I think maybe
That's
we should suggest that, why not start it from the hospital itself,
yeah. It is
the
started from the
CBG
hospital,
patients.
and
Great.
then post discharge there was no follow up and all. So that has been taken care. I was working the Fortis Mulund only, so that project is taken care, and that has become a protocol.
Okay, great. Dr. Shubhangi, if
Yes,
you have something,
yes, ma'am.
just take a minute and,
Yes,
discuss,
ma'am. Yes, ma'am.
and then we
Good
are
evening,
wrapping
ma'am.
it up.
Yeah, good evening, madam. This is my experience. Like now, we have got one very senior patient in intensive care unit was underwent a major surgery. I just wanted to say tell about the other side of the mobilization. And the patient was very bad after the surgery, and patient we kept on ventilator for a longer duration, and then this prone position, ventilation. We tried to mobilization. Even we tried to mobilize the patient. We made her to sit on the chair with the ventilator and all. So lot of mobilization we were doing. And after my night duty, I just went for 3 days off. And then fourth day I came because the patient was in ICU for a longer duration. I was worried. I came to know the patient is died, patient expired. So that immediately in my mind came like, no, keep, we have mobilized the patient's embolism or what? Maybe there were some complications, and because of a very rigorous mobilization, have we mobilized the embolism so that the patient, it was harmful and patient we lost. So that was one experience,
Okay.
my experience about.
No. It is very much possible because assessment is very important.
Yes, ma'am.
Now, the patient, whether they have any risk for embolization is something that literally that someone needs to know, because you cannot jump into mobilization without
Yes.
understanding the patient themselves. It is very important. So anything that we start, it starts with first assessment.
Yes,
So
ma'am.
BMAT is only used about how the patient can be mobilized. But what is the patient's diagnosis? What are the risk factors within the diagnosis? Can that patient be, what is the blood profile of the patient? What's the diagnosis? Is it thick blood, thin blood? What are the, risks that you can have? Because I'm a critical care nurse, so I understand the challenges one can face when. So I think we should take baby steps, where we can prove that it is working. And then I would always suggest, why not start with the patients who are in the ward, where it is proven, that they need early mobilization for anyone to be, think of, elderly patients who are in bed, they come for 2, 3 days admission, they go back home, and all 2, 3 days, we don't even bother thinking that they're very old. They don't come and say that you should walk, because I was with my mother, nobody bothered. I had to tell her, you're going to get up and 3 times we are going to make rounds in the room itself. Is because I know that I cannot look after her at home if she will not do these things in the hospital itself. And that happened because I was the attendant. If I was not the attendant, I don't know what would have happened. So I think it's very important first to learn the concept of early mobilization. Know there are evidence-based tools available, practices available, and both stories are important. The post discharge, how people can get better if you give them extended advice. And also Dr. Shubhangi's story that it can lead to worst outcomes. You never know, because unless and until you do autopsy, you will never know why did the patient die. And so embolization usually happens very quickly, not over a period of time. If it happens, it happens. That's how it is. So I think, ladies and gentlemen, fantastic session. And thank you. Thank you very much. We had almost 80 plus people in the session. We still have 66. So thanks a lot, Jyoti and Saujanya, for taking through this very unique, session, which gives a scope for everyone to plan whether, they would like to use that in their hospital. This is very, very important. Thank you. Thank you, everyone, for being here. And good night. And those who
Just
have
a minute, ma'am.
feedback.
I would definitely take this opportunity to thank Arya Thankam ma'am for giving me this opportunity to have this webinar on actionable evidence-based practice on early mobility management. Thank you so much, ma'am, for all the guidance that you have given. Very, very grateful to you. And thanks to my mentor, Saujanya, for for making this presentation good, and for morally supporting me to go ahead for this presentation. So I really thank you, ma'am, from the bottom of my heart, because this journey, this particular early mobility, somewhere, because it is me who chosen this, I said that, ma'am, I really want to do this because I felt it is something new, and I'll have something to learn. And it was definitely a rich learning for me, something to talk, to share, and then, to implement probably in my hospital setting as well. So Thank you
I'll be
so
more
much.
than happy that you implement this in your hospital, and I can always spare some time to give some more input into that, and actually making a protocol. You may have to change few processes to
Right,
put
ma'am. So we
involve.
have a new rehab center, ma'am. So probably we can have this all incorporated in that.
Great. Okay.
So we'll.
All right. Thank
Thank
you.
you,
Both
ma'am.
of
Thank you
you,
so
and
much.
God bless you. And thank you, everyone
Thank
who
you.
Thank you, ma'am.
Thank
Thank
you.
you.
And
Bye.
look forward to seeing you all on 24th. Don't miss it. You might be thinking hand hygiene. Oh, I know everything about it. Please come. You might learn something new. I will definitely tell you something new. Okay. See you all there. Bye bye.
Thank you, ma'am.
Bye
Bye,
bye.
ma'am.
Thank you, ma'am. Good night.
Good night.